In this poster, we examine the sustainability of Japan's universal health system in the context of a super-aging society. Japan is a top performer globally with very high life expectancy and strong fiscal financial protection through its statutory health insurance system, SHIS. But that success is under pressure. The population is aging rapidly, long-term care needs are growing, and the system remains very hospital-centred. Japan has one of the highest bed-to-population ratios and longest hospital stays in the OECD, and hospitals are often used as a substitute for long-term care. Primary care is relatively weak, and SHIS is separated from long-term care insurance (LTCI), which fragments services. So our core question is, how do you keep universal coverage sustainable in an aging society? Our argument is that Japan has to move away from hospital-based incentives towards a more integrated community-based model. We use the Deplacet framework to analyse the contextual factors. Demographically, Japan is a classic super-aging country. About 29% of the population is over 65. The old age dependency ratio is roughly 51% versus 34% for the OECD, and fertility rate is about 1.2, which has been below replacement levels since the 1970s. This means fewer workers are supporting more elderly people who need care. Epidemiologically, non-communicable diseases now account for about 85% of deaths in Japan, with malignant neoplasms, heart disease, and senility dominating the top three. That's a profile of an old population and implies a shift from acute episodes towards a need for prevention and long-term management. Economically, aging and NCDs push spending up. Health expenditure is around 11 to 12% of GDP, above the OECD average, with a public debt of roughly 255% of GDP. Therefore, the fiscal space is limited, and raising contributions is politically risky. On that note, Japan has had a stable government with the Liberal Democrat Party dominating the last 70 years, but attempts to raise co-payment caps under the high-cost medical expense benefit scheme triggered strong backlash, showing how hard it can be to shift costs onto households. Socioculturally, the traditional family care model is weakening. Multi-generational households have declined, more older people live alone, and many women delay marriage and childbirth to avoid rigid gender roles. As family care recedes, the state must fill the gap with formal long-term care and community services. Legally, universal coverage and free provider choice are guaranteed, but that also locks in problems. Patients can see any provider without gatekeeping, which encourages direct hospital use. Hospitals must be non-profit, limiting consolidation, and over 3,000 insurance schemes fragment administration despite standardised prices and benefits. Ecologically, Japan's position on the Ring of Fire means earthquakes, tsunamis, and extreme weather are constant risks, with climate-related heat waves particularly threatening to older people. And finally, technologically, there is real opportunity in Japan. The nationwide medical information platform aims to integrate patient data and telemedicine. Remote monitoring, AI, and robotics can also help manage workforce shortages and support older adults and rural communities. Moving on to goals. Before examining performance, it's always useful to recall the main health system goals as laid out by the WHO. Effectiveness, efficiency, fairness in financial contribution, responsiveness and equity across groups and regions. Japan explicitly pursues these through universal coverage, strong financial protection, and free provider choice. But tensions are emerging, maintaining high effectiveness while improving efficiency, balancing free choice with coordination needs, and protecting equity as older rural regions lose population and capacity are becoming more difficult. In terms of performance, despite these tensions, Japan is still one of the best performing, if not the best performing, healthcare system in the world. Life expectancy at birth is over 84, which is roughly 4 to 5 years older than the average OECD. Infant mortality is 2 per thousand, is under 2 per thousand, compared with 4 in the OECD, and healthy life expectancy is also higher, both at birth and at 60. The issue is how these results are achieved. Spending is above OECD averages at 11.4%. Hospital bed density is around 3 times higher than that of the OECD. And additionally, the length of stays are very long. That suggests inefficiency, over-reliance on hospitals, and using hospital beds as a substitute for strong primary care and specialised long-term care. In terms of stewardship, Japan is highly centralized. The Ministry of Health, Labour and Welfare sets policy and defines a national fee schedule applied to almost all providers. This schedule, revised every 2 years, is the main tool for cost control. Implementation is more decentralized. Prefectures plan regional services like hospital beds and emergency care, while municipalities run national health insurance and long-term care insurance and organise community services. Structurally, there are over 3,000 insurers ensuring coverage but fragmenting risk pooling and administration. Regulation and pricing are central, service delivery is local, and regional variation in access persists. For access, the key point is no gatekeeping. Patients can go straight to specialists or hospital outpatient departments. Outpatient care is mostly provided by small private clinics, inpatient care by private non-profit hospitals, and long-term care by separate providers funded through LTCI. Because SHIS and LTCI are financed and managed separately, coordination around discharge is weak and hospital stays are longer than needed. So governance works well for cost control and coverage, but less well for integration and shifting care from hospitals. On financing, Japan uses a multi-payer model with 3 main sources: insurance premiums, general taxation, and out-of-pocket payments. The high-cost medical expense benefit caps monthly out-of-pocket costs by income, underpinning strong financial protection. Government adjustment mechanisms redistribute funds to support high-risk populations, especially older adults. Most providers are paid fee-for-service with prospective per diem system, DPC, in many hospitals. Clinic doctors, often owner-operators, can earn substantially more than salaried hospital specialists. These payment structures reward volume rather than coordination, reinforcing the hospital-centred model when Japan needs stronger primary and community care. Service delivery still leans heavily on inpatient care with very long stays, weak primary care, and limited community-based capacity. Transitions between clinics, hospitals, and long-term care providers are often fragmented. The split between SHIS for medical care and LTCI for long-term care contributes to delayed discharges and regional variation, particularly affecting rural elderly, underlining the need for a shift towards integrated community-based services. Given this, we propose our reforms towards sustainable, community-based integrated care. 1. Strengthen primary care. We suggest encouraging registration with the usual primary care provider as first contact, soft gatekeeping in other words. Payment would shift to a mixed model, risk-adjusted capitation for registered patients, fee-for-service for defined acute episodes, and pay performance for prevention of chronic disease management. Registration and capitation would shift care into communities and give primary teams clear coordinating responsibilities. With an older population and NCDs dominating mortality, prioritising prevention and long-term management is essential. We also propose expanding case-based payments like DPC and DRG for inpatient care, reducing per diem reimbursement, alongside length of stay benchmarks including linked to payment and stronger incentives for ambulatory and day case care. High bed numbers and long stays suggest beds are used for social rather than acute needs. Episode-based payment with benchmarks would reward efficient, safe discharge and collaboration with community LTC services. Thirdly, integrate health and long-term care. We recommend closer SHIS to LTCI coordination through joint planning and budgeting for older people, shared care pathways and interoperable systems. Savings from reduced hospital stays should be reinvested into LTC capacity and digital tools supporting older adults, especially those living alone or in rural areas. Currently, the SHIS LTCI split contributes to delayed discharges and social hospitalisation. Integrated budgets and pathways would facilitate moving patients to rehabilitation, home care or residual care at appropriate times. Finally, increasing technological tools. A key step includes fully rolling out a nationwide medical information platform, scaling telemedicine and remote monitoring for chronic disease and elderly care, and using AI for diagnostics and care coordination while ensuring older people aren't excluded by digitalisation. Digital infrastructure underpins all reforms. Shared data improves continuity and planning, while remote monitoring and teleconsultations help keep older people stable at home and support rural communities. To conclude, Japan's health system delivers outstanding outcomes and strong financial protection, but superaging, high public debt and a hospital-centred model mean that the current approach is unsustainable. The key issue isn't just the spending amount, but how money flows through the system and what behaviours it rewards. By strengthening primary care with capitation and gatekeeping, reforming hospital payments for episode-based care, integrating health and long-term care, and leveraging digital tools, Japan can move towards a more community-based, value-driven model and keep universal coverage sustainable in a super-aging society. Thank you for listening. All references are listed on the supplementary slides.